Assalamu alaikum. Hello, dear friends. This is one of a series of videos about hospital policies and procedures, which are written instructions on how staff members do different processes. Policies are general rules that govern our performance, and procedures are sequential steps on how we do it and the responsible person for each step. We can update these rules when we have new standards to follow. In this video, we will talk about the policy of care of patient on life support. For more videos, please visit my Facebook page, Healthcare Quality, and my YouTube channel, Dr. Hassan Kamel. If you like it, please support me with likes and follow. This policy is applied to all hospital services provided to patients on life support. The purpose of this policy is 1. To provide the guidelines for the care of patients who are critically ill and on life support systems. 2. Organ failure of patients on life support is to be resolved as soon as possible to maintain other organ functions. 3. Maintain safety of patients on life support. Definitions. 1. Life support system. Life support in medicine is a broad term that applies to any therapy and techniques used to sustain patients' life while they are critically ill or injured. Feeding tubes, intropes, total parenteral nutrition, mechanical ventilation, heart-lung bypass, urinary catheterization, dialysis, cardiopulmonary resuscitation, defibrillation, and artificial pacemaker. These techniques are applied most commonly in the emergency department, intensive care unit, and OR. As various life support techniques have improved and evolved, they are used increasingly outside the hospital environment. For example, a patient who requires a ventilator for survival is commonly discharged home with these devices. Life support techniques may also be used indefinitely if the underlying medical condition cannot be corrected, but a reasonable quality of life can still be expected. 2. Most responsible physician is the treating doctor, usually a consultant. Policy statement. Number 1. The care is delivered preferably in an intensive care unit, but in some circumstances in the wards too. Number 2. While the primary aim in the acute critical condition remains to stabilize the patient and provide hemodynamic and airway support, simultaneously the prolonged care needs of patients on life support must be identified early and discussed with the family. However, some patients on life support may improve completely from the underlying condition, while the others may not resolve completely. Number 3, the needs for protection of airway and life support are detected early to prevent the complications. Life support is provided according to the underlying condition or disease of the patient and is dealt individually. Number 4, The circulation in the patient who is in life support often requires continuous support, so early good intravenous access is required, while measuring of the pulse and blood pressure and appropriate treatment. Equipment. Here are some examples of equipment required for patients on life support. Procedures. Number one, patients who require life support therapy are identified by most responsible physician or his or her team, which include any of the following. A. Hypotensive patients, patients in shock, who require hemodynamic support with volume resuscitation and valprostrol inotropic agents. B. Patients with severe respiratory failure in need of ventilatory support. C. Comatose patients who are unable to protect and or clear their airways, and those with severe upper respiratory obstruction who require artificial airway management and subsequent mechanical ventilation. Number two, the most responsible physician multidisciplinary team, including the assigned nurse, assess the patients who require life support, make diagnosis, and identify the needs of the patient. The initial assessment includes history, including the medications history from the relatives, physical examination, provisional diagnosis, special needs assessment, psychological screening, pain assessment, need for additional specialized assessment, and assessment of the nutritional status of the patient on life support initially, at admission, and regularly when needed. Number three, the team plans the care accordingly. Long-term management involves consideration of the problem suffered by a patient on life support system lying still for very prolonged periods with no protective reflexes. These include pressure area care, care of the mouth, eyes, and skin, physiotherapy to protect muscles and joints, risks of deep vein thrombosis, risks of stress ulceration of the stomach, nutrition and fluid balance. When needed, clinical dietitian consultation and development of a multidisciplinary nutritional plan is drawn. Urinary catheterization, hemodynamic monitoring, infection prevention and control, general standard precautions and isolation precautions should be strictly followed as applicable by all healthcare personnel involved in the care of these patients. Maintenance of adequate oxygenation with the assistance of artificial ventilation if indicated, and applying VAP bundle. Eye care important because of loss of ability to close eyes, conjunctival exposure, and increased risk of dryness. Education. Considering the difficult time for the family, the caregiving team will educate the family and provide with psychological support, explain the outcome and prognosis, and document in the patient medical record. This helps the family to understand the complex situation and take difficult decisions. Nursing care plan of patient on life support. The assigned nurse will do the following. Ensure clear, patent airway to lessen the risk of aspiration. Ensure adequate respiration. Monitor vital signs. Assess level of consciousness to assess motor and sensory functions. Never leave the patient unattended. Put up side rails to provide patients with safety. And document the procedures and monitoring findings in medical record and report any unusual findings in the patient's condition to the physician on duty. Number 4, as the patients on life support are more dependent for their care on healthcare professional, so they are given special attention and services that are more specialized. The most responsible physician will admit the patient to ICU for provision of care whenever and wherever found critically ill. Number 5, after admission to ICU or after receiving the ICU consultation for those patients in ER or ward, initial assessment of patients who need life support therapy will be performed by the ICU physician on duty and completed within time frame. Number 6, the ICU physician in charge develops the plan of care for each patient on life support, which is reviewed and verified by most responsible physician if patient is in ward or ED. For patients who are treated in the ICU, the most responsible physician provides suggestions. The ICU physician in charge is responsible for implementing the plan of care in ICU. Number 7, if the patient survives on life support systems, then patient care team plan for prolonged supportive measures and procedures which will include but not limited to the following and document on the patient's medical record: tracheostomy, percutaneous endoscopic gastrojejunostomy, suprapubic catheterization, and physiotherapy. Number 8, all life support dependent patients carry a high risk for injury, fall, and abuse. To protect them from harm, following procedures are applied. An attendant at all times, preferably a nurse, but can be a family member or caregiver in ward. Side rails of the bed and or safety belts in place. Airway management equipment at hand. Suction equipment at hand. And restraints as needed according to restraint policy. Responsibilities. 1. Most responsible physician and or ICU physician identifies the patient in need for life support. Assess plan care of patient and reassess the patient. Monitor the effectiveness and complications of the treatment. Writes the order and supervise their implementation. Educate the family and provides for psychological support. 2. Assign nurse. Assess and reassess the patient, identify his or her needs, and plan nursing care. Follows the physician's orders, plan of care. Performs pain assessment and reassessment. 3. Social worker. Communicates with the patient family as required. Psychological support for the patient and family. 4. Dietitian. Assess the patient regularly and discuss with physicians, nurses, and family about the patient's diet feeding needs. Assist the family in long-term diet care. Approval of each policy is usually done by the preparing person, recommended by the department head, reviewed by the nursing supervisor, and approved by the quality director, medical director, and hospital director. Thank you.